Thanks, George. I think we've done an awful lot in the last year to really settle this controversy, as I'm going to show you now from the totality of the evidence. And I will argue that the data supports PCI in most cases, and that that's what patients want. These are my relevant disclosures. So we've had a lot of discussion about the heart team. And the heart team has a goal, and its goal is not what I want as an interventionalist or what Dr. Frames wants as a cardiac surgeon. It's what the patient wants. And we're supposed to be able to inform the patient with the best evidence, taking into account his or her individual circumstances to help to propel them to their goals. So what do patients want? Well, most patients do prefer PCI compared to CABG for left main disease or any coronary disease if it's a reasonable thing for them to do. And the reasons are very obvious. I mean, I think surgery is a fantastic procedure, but it's a lot to go through. And there's substantial recovery time that's required, and there's a setback for the patient to get over the trauma of surgery, if you will. As you see from these pictures, a left main patient 24 hours after surgery versus 3 hours after PCI. And this is actually sometimes more obvious to our patients than it is perhaps to us when we're focusing on data and long-term outcomes. So the principle of autonomy dictates that patient's choice must be respected. Patients would like to undergo a lesser invasive procedure of any type, if possible. So the fundamental question then is, whom are the advantages of CABG so profound that we should strongly recommend that patients go through the considerable discomfort and prolonged recovery that surgery entails? And I think in this regard, you have to put yourself in the patient's place or your family members. So what do patients want? Well, in addition to obviously having as simple and safe and easy to recover from procedure as possible, when you look at what patients want compared to what physicians want, it's often different. Physicians think that mortality trumps all and other endpoints are much less important. Patients, on the other hand, think that stroke and large myocardial infarctions are at least as important as survival. And then they think that other types of recurrent angina and repeat revascularization are much less important. So for patients, those three endpoints are very important. Everyone would agree that mortality is probably at the top of the pecking list. So now we can ask, is mortality different between left main PCI and CABG? And I would say without any doubt, the definitive database is the individual patient data pooled analysis from the 4 contemporary randomized trials of DES versus CABG with 5-year follow-up. And all the principal investigators said we have to solve this issue. And so we gave our databases to Eugene Brunwald and Mark Sabatine at the TIMI study group and let them do their own analysis. So 4,400 randomized patients, including Excel and Noble and Syntax and pre-combat, and there was absolutely no significant difference at 5 years in mortality between surgery and PCI. A 1% difference, not statistic P of 0.33. By Bayesian analysis, if there was any difference at all, it's likely less than 0.2% per year, less than 1 in 500 patients per year. That's what this slide shows. We have 2 of those trials went out to 10 years, and at 10 years, actually the curves converge, kind of what Dr. Guardino just showed you with medical therapy versus CABG. The longer you follow them up, the curves are more converging. So absolutely no long-term difference in mortality. And if you look at all the predefined subgroups, there was no difference according to preserved or depressed left ventricular ejection fraction. Diabetes is not a discriminator of mortality in left main PCI patients. And in fact, even the Syntax score had a negative interaction p-value of 0.48. But this was explored in great detail in spline analysis, looking particularly at cardiovascular mortality, which is where you would expect to see any difference if there was going to be a difference. And up to a Syntax score of 33, there clearly was no difference in mortality, or if anything, the point estimate slightly favored PCI. But after a Syntax score of 33, then mortality starts to favor CABG. And by the time you get really high, up to 45, that's when it became significant. So in the really anatomically complex patients, there may be a survival benefit for surgery. Now you have to offset that with the second most important endpoint, which is stroke. And stroke rates are different. And in this analysis, there's about a 1% absolute difference in stroke in the early peri-procedural period, and that extends out to 1 year. And then there's accrual of events in both groups, which somewhat narrow the curves. But about 1 out of 100 patients more will have a stroke after surgery compared to PCI. That will be more important to some patients than others, and especially patients that are at higher risk for stroke. What about myocardial infarction rates, the third endpoint? Well, here we've got offsetting benefits and risks. Large procedural myocardial infarctions are less with PCI than CABG, but spontaneous MIs during follow-up are less with CABG than with PCI. Overall MI rates not a whole lot different. Well, what about all the other outcomes that matter so much to patients? Recurrent angina, chest pain, musculoskeletal disorders, other procedural complications, infections, bleeding. What about atrial fibrillation requiring chronic oral anticoagulation, vascular complications, repeat hospitalizations, repeat revasc? And what about the more subtle things, cognitive decline, depression, time to recovery? Well, again, what patients really want is to live longer and live better. And I talked to you about living longer, that's mortality, and living better. All of that can be encapsulated in quality of life outcomes. And when you look at the formal quality of life studies that have been done, you actually see that early on there is a difference in quality of life. And it's substantially better with PCI than CABG. And this reflects the difficulties of going through the peri-operative CABG period. So if you look, for example, at the SF-12 in the randomized Excel trial, early on after PCI, patients are substantially feeling better at 30 days, and they feel slightly worse after CABG. And it takes up to about 6 months for the patients to recover. That is a lot to ask patients to go through, so you really have to have a lot of benefit before I would want to go through it, let alone a patient. There's also faster recovery of mental functioning after PCI compared to CABG, and then there's a catch-up by 6 months, and then it's equivalent again, just like physical status over time. Depression is substantially greater after CABG compared to after PCI for at least 12 months after the procedures. And both procedures are excellent at relieving angina, okay? Maybe a small, tiny difference in this analysis that favored PCI at 30 days, but marked improvements in angina relief. So patients are having minimal angina after both PCI and CABG, and that's sustained out to 3 years and beyond. So Dr. Guardino, leading cardiac surgeon, Michael Farku, who ran the FREEDOM trial, and I put together and recently published in the European Heart Journal a unified perspective of how we interpret the totality of the evidence to inform patients. And we decided that, first of all, PCI and CABG are very different procedures with different risks and different benefits. For many patients with left main disease, the choice between PCI and CABG will be agreed upon by all subspecialists. CABG will be strongly preferred by the heart team for many patients, particularly those with extensive non-left main related coronary disease. In contrast, PCI is going to be preferred very clearly by all members of the heart team for patients such as those with frailty, severe COPD, prior stroke with residual defects, etc. For other patients in whom revascularization can be safely completed with both procedures, that is, when equipoise is present, there'll be substantial and comparable long-term improvements in survival and quality of life after both PCI and CABG, although the journey is different. Early on, it's easier after PCI, and then there'll be fewer later events after bypass surgery. So in these cases, the patient needs to be informed, and patient preferences regarding the early versus late trade-offs of the procedures should inform clinical decision-making. Thanks very much.